Welcome to my channel. I'll be talking about vegetative state. You will enjoy this if you have listened to Lazarus syndrome and locked-in syndrome already published. Vegetative state or persistent vegetative state. Many found the term very offensive. As a matter of fact, many doctors are not comfortable naming or classifying any patient as being in a vegetative state. There are some familiar terms when it comes to vegetative state: brain death, coma, locked-in syndrome, vegetative state itself, and persistent vegetative state. Here, my channel, I will publish brain death presentation after this very presentation, coma in another day, locked-in syndrome already published, Lazarus syndrome already published. This is vegetative state, and we will cover persistent vegetative state right now. Okay, vegetative state. Before we make that diagnosis or think about vegetative state at all, the affected individual must have been in coma before, now woken from coma, but no awareness yet. He or she can open the eyelids and there will be entire sleep-wake cycles. Isn't that great? But not great because the affected individual is not fully with us, but can sleep and wake up. No more cognition. Some even call this coma vigil. Full recovery is inversely proportional to time spent in vegetative state, meaning the longer the patient is in vegetative state, the poorer it is to recover, or recovery is less possible. So, shorter time vegetative state, better time to have full recovery. The longer you spend there, the less the likelihood of full recovery. Persistent vegetative state is debatable depending on your jurisdiction or country. You have to review the previous slide to get the full picture of persistent vegetative state. It means staying in a vegetative state for a long time. 4 weeks in vegetative state qualifies the patient to be tagged persistent vegetative state patient. It is called a continuous vegetative state in the United Kingdom. In UK, after 12 months in vegetative state, it is termed to be permanent vegetative state. Higher function may never be regained again. Let's be cognizant of what we are dealing with. We should be aware that there are lots of medical legal issues surrounding all these terms. Some doctors are uncomfortable to even, classify any patient as being in vegetative state. Even then, to those who did, there are lots of medical legal issues surrounding the terms. But to save your license, contact your hospital or health authority in your place on these terms and the legal implications. Signs and symptoms of someone in a vegetative state will include no response to command or any external stimuli. Some may respond in varying degrees, like eye could be open to feeling, but you can't find that in someone in coma, right? They can swallow. They would have lost cortical functions, but brainstem functions will be entered. That's great. Reticular activating system will keep on controlling the sleep-wake cycle. Great, right? But they will have non-directional eye movement. They can be in chronic wakefulness, entire eye opening with entire vocalization like crying or laughing. They might have normal sleep, like what I've just said, like reticular activating system is intact, and non-directional movement. Unsynchronized eye movement, like I've said, I think I've repeated this now the third time. Teeth grinding, smiling. Don't think they're happy. It's just shedding tears, grunting, mourning, screaming without a cause. That will be a burden on the nurses who will have to respond to every sign that comes from the room where the patient is. Recovery depends on a lot of things. It depends on the cause of the vegetative state. That is the major factor of factors that will determine the recovery. For example, if the cause of the vegetative state is trauma, more people with trauma will likely recover than people with stroke. And recovery could be in weeks. Better chance in younger people, maybe prolonged to weeks and months with diminishing recovery chances. Like I've said, full recovery is inversely proportional to the time spent in vegetative state. After 1 year, it is not very likely that the individual will have full recovery any longer. Causes: acute traumatic brain injury, non-traumatic neurodegenerative disorder, metabolic disorder, congenital abnormality of the central nervous system, infections like meningitis or encephalitis. Other causes could include increased intracranial pressure, intracranial hemorrhage, ischemic stroke, hypoxic ischemic brain injury, sepsis, encephalopathy. Others include diabetes mellitus, concussion or contusion, thyroid disorders or toxins. How do you make the diagnosis here? Full history, full physical examination, and of course follow the vital signs. That is how we start. If we have not known the exact cause of the problem and we just want to come down on specific cause, we'll head to lab again and let's have thyroid function test done. What about the electrolytes? What is happening to the complete blood count? How about the glucose? Toxins here, toxicological screening, that will help also with street drugs and so, lactate in the blood and CSF, acid phosphatase, glutathione, creatinine kinase, neuron-specific enolase. If we've not made the diagnosis yet, okay, we can then start radiological investigations, brainstem auditory evoked potential, CT angiography, magnetic resonance imaging, SPECT, EEG, EKG, somatosensory evoked potentials. Prevention, they say, is cheaper than cure. So we have supportive management. Remember to replace all replaceable, prevent further damage, adequate nutrition, aseptic procedures, and prevent venous thromboembolism. Also, we must prevent gastric ulceration. Now, the treatment. Family support will be very great and very helpful to family members, to the loved ones of the affected individual. You can involve psychologist or your social worker at this point. Please carry the substitute decision maker and family members along from the onset and all through. Determine the time of termination of the life support with your team and family members. Multidisciplinary approach will be very helpful. Physiotherapist will be needed or may not be, depending on what your jurisdiction will approve. Speech pathologist, something as simple as warm blankets in case of hypothermia. Vasopressors, by some. Neuro and pharmacologists should be, receiving consult to participate in the management. Still part of the treatment could involve deep brain stimulation, tricyclic antidepressants. Some use methylphenidate, and you can treat infections with the antibiotics. Clonazepam or valproate have been used by some for myoclonic seizures, but because they have abnormal movement sometimes, so it's difficult to say that it is actually seizures because it may not be seizures per se. All this, as per the treatment, nothing is fixed. So it depends on what is obtainable in your jurisdiction. So find out what your center will approve. With that, I've come to the end of this very short presentation. This is not a good condition that anyone will wish to be. So to those who are there, I'm wishing them the way out. Thank you for listening. Remember to subscribe. Remember to share. I appreciate it.